Thank you, everybody, for joining. I think we can start tonight's discussion. I'm going to welcome Professor Moodley and Dr. Carol-Ann Benn to start their cameras and join us. A little bit of housekeeping before we get going tonight. We always encourage audience interaction, so feel free to post your questions in the chat or use the Q&A there. I will make sure when we have a gap in our discussions to ask those questions to our specialists. And there will be a recording of tonight's session on the Breast Health Foundation social media page afterwards. So without further ado, we'll have one final thank you to the Breast Health Foundation for facilitating these webinars. It's always lovely to see the audience interaction and the interest that everyone has coming forward to this. And let us start tonight's discussion. So tonight, the topic of our webinar is Innovations in Oncology, the future of breast cancer treatment. Our aim is going to explore groundbreaking advantages that are shaping breast cancer care. Joining us are esteemed experts, Professor Carol-Ann Benn and Dr. Devan Moodley, both of them who are on the leadership committee of the Breast Center of Excellence in Johannesburg. We encourage active participations, and we're going to have 3 different discussions tonight. The first one we're going to kick off for is innovations that are currently in practice in breast cancer. And I'd like to invite Professor Benn and Dr. Moodley to discuss what they think are the most relevant changes that we see actively being used in breast cancer treatment today.
Right. Thanks, Dom. So I want to start off by saying that I think the world's changed so much, and I think a lot of innovations happened around the SARS-CoV-2 pandemic, because previously to that, and Devin and myself would we call ourselves a little on the old side? I think we're young at heart, but we have been looking after people with breast cancers for 30 plus years. And for a long time for me, a frustration, and that's why I always reach out to Devin, because he has a brain that sees the innovations in the future and always understands, is that medicine and breast cancer was very much, you wait 5 or 10 years for the data to change, and it was just such a slow process. So what we've really, really worked out is it's about the patient. Each cancer is different, each patient's different, and it's about escalating careful, personalized care to the patient after a robust multidisciplinary discussion. And that means not where everyone agrees with one another, but where we actually bring out new ideas. I loved yesterday, Byron came up with this, everyone came up, and I love, Devin, that you have got such a depth and power of knowledge to understand that. I did a Teams last night of a lady who you've got on a really funky new concept of, and we can talk about that, PHESGO and CDKs and endocrine, and her cancer's melting away. Previously, in the old days, these people would probably get things like chemo. So things have changed. Cancers, it's about personally understanding the cell, understanding the patient, and putting together what's best and making sure you have a show me the data way of making sure it works. So I'm interested to hear what Devin says.
So innovations in oncology, it's pretty broad. So I thought, if you're going to talk about this, you need to chop this up into little bits. Okay. The first thing that I think you need to say a little bit about is precision medicine and genomics. And here we can talk about things like lung cancer, where we change the way we treat people. We target particular mutations, and we use new tools like next generation sequencing to identify those targets and treat them. So each target has a requisite therapeutic arm. So you find a target, you have a therapy against the target, right? So that's the first part where I see cancer changing tremendously. The second part is immunotherapy. Immunotherapy has been around for a while now, and basically immunotherapy is a process by which, instead of attacking cancers directly, we find mechanisms to boost the body's own immune system get the immune system to fight the cancer. Now, many of you may have been exposed to things we call checkpoint inhibitors like Keytruda, pembrolizumab, or CAR T cell therapy. Now, CAR T cell therapy is where we take the patient's own T cells and engineer it to destroy cancer cells. And this shows immunotherapy has shown a lot of success in things like melanoma and a lot of success in things like leukemias. Then there's targeted therapies. Now, targeted therapies are drugs that focus on specific molecules involved in the cancer growth pathway. So what they tend to do is they tend to kill more cancer cells than other cells. So they cause less damage than chemotherapy. Doesn't mean they don't cause damage. It says they cause less damage. They're often used in combination with other treatments. Okay, so a particular example of this is the age-old example of HER2 therapy in breast cancer. So we hardly ever give HER2 therapy alone. We give it in combination with other drugs. Then we have innovative therapies, innovative mechanism to detect cancer through simple blood tests. Okay, so we do things we called liquid biopsies. Okay, so how is that helpful? Well, liquid biopsies detect circulating tumor DNA, and this is very useful for detecting cancer, monitoring treatment results, and spotting early relapses. So there's more and more these days where we use these tests to say, hang on a second, your cancer now, I know it's still fine, but literally within the next couple of months, you are unlikely to continue to respond to a therapy. Then there's a thing called radiopharmaceuticals. So in many disease processes, what is happening is that we combining radiation and targeted molecules. So we're putting them together. So what happens is you deliver treatment directly to cancer cells. Okay, so we use this especially in things like prostate cancer. But what is happening more and more, and we've got a new trial coming up where we're going to use this in breast cancer, where we can do fancy scans like PET scans, but these are PET scans with specific radioligands. We then combine them with therapies for breast cancer. And then we got organoids and personalized testing. And what it does is it allows testing of multiple drugs to show you, well, how will they work against a particular cancer? Okay. And that's very, very interesting. One of the biggest innovations we have to learn to manage is AI and machine learning. So as we get through things like quicker, fancier diagnosis, better treatment planning, better drug discovery, we find that machine learning and AI can catalyze that process. It can look at images better and quicker and give you answers faster. And it helps to identify patterns within large data sets to predict outcomes. So it's actually just a fancy algorithm, which up to now you've been relying on your doctor to have here, that we can put now onto a computer, providing that all the inputs are fine. And please don't be mistaking this. We are still in the early stages of this. But as this grows and grows and grows, we can find that it gets better because of the inputs. So one of the places this would work very well is early detection. So we can see that as imaging improves, machine learning and AI also improves in detecting things way before we would ordinarily have detected them before. And one of the benefits of these things is it lessens the cost of medicine. It allows a more equitable access by making diagnostic tools cheaper. And then the other thing is, with telemedicine, we can now reach more people. And you will find that what Carol and I do every day is now every day I have at least 1 or 2 patients that I consult online. Whereas a little while ago, we didn't do any of that. Those would be a summary of all the things I see as innovation in oncology.
So Dom, I'm just going to step on to what Devan says and try and give a blunt explanation. So the first thing is, how do you diagnose a cancer? And absolutely, machine learning is helping us pick things up quicker, number one. Number two is you need to have a diagnosis of understanding the cells. And by understanding the cells, you can do that in whether you do core biopsies and you use AI learning as well, digital pathology, better understanding of what I call torturing out the cancer cells to understand how they behave. And you can look at them both at the local area where they arrive, and you can look at them in the bloodstream now to work out what is the best ways to treat things going forward. When it comes to surgeries are innovatively getting less is more and smaller. In fact, maybe there will be aspects, we're already seeing it with glands, etc., we will be doing lesser or no surgeries, okay? And the studies are out there and they're coming thick and fast, okay? When it comes to targeting things, we're using, once we have that all through a multidisciplinary approach, the oncology team can turn around and go, for you, you don't need what I call recipe medicine. Chemo, this surgery, radiation. You can now have specific for you with a multitude of different drug options of how to make sure we have, and that's why I'm always a fan of giving some form of oncology, not saying chemotherapy, treatment first to understand behavior of cells, and then work out what we're going to do. So more specific, more personalized, clever understanding of the cell, more specific about all our different drugs and medicines. Yep.
Fantastic points you bring up there. And from both Dr. Moodley and Prof Ben, one of the aspects I really liked your discussion is when we hear innovations in medicine, we immediately think very scientific. New drugs, new medicine, new everything. But you've brought up the point that it's not only about the medicine, but the entire journey, the supporting systems, the fact that we do now offer aspects such as the virtual consultations is an often overlooked innovation that gives great benefit to most of our patients, as well as the discussion with AI as a tool, not as a solution, but it's there to assist our medical fraternity as a whole. I've taken down a couple comments that you mentioned there, Dr. Moodley, that I'd love you to elaborate a little bit more on the more scientific questions about the innovations. You did mention targeted therapy and hormonal therapy. I'm going to take it back one step to where we see the origin of when we were talking with an oncologist. Oncology to a lot of our patients, so when you learn and look it up online, it's still a very archaic term where you immediately think chemotherapy. But you've seen a drift nowadays of changing it from, it's not just chemotherapy, it's systemic therapy. Let's discuss a little bit around the change over the last maybe 20, 30 years from oncologists giving just chemotherapy to more of these systemic therapies you mentioned, like the HER2 and the advances in the HER2. How would you respond to that?
Excuse me. So I think what you need to understand there is, simply put, it depends where you go. It depends what the motivation is to change, and it depends on how up to speed you are with what is the way to go. So let me make that a little bit easier. So firstly, the first hurdle we have is that there are some of my colleagues that don't keep up to speed. They work where they work. They're accustomed to treating patients in a certain way, and they don't change. because as far as they're concerned, for instance, a mastectomy is the only way to treat breast cancer, right? So that's the problem we often faced. So we face a similar problem in cancer therapy. Firstly, systemic therapy. So we have an entire body of patients, the vast majority of patients that are not exposed to so-called newer systemic therapies. And the reason for that is, number one, access. So they don't have a particular access in terms of, let's start at the beginning, the government service, right? So the government doesn't pay for that level of care. It's too expensive. Or one may argue, it's not really on their radar to prioritize that in terms of patient care. It doesn't really, you could say, get to the people, or the cynic would say it doesn't buy them votes. So they're not prepared to spend that money in terms of looking for treatments that are more specific and indeed better. So what happens then? Like the specialist who hasn't kept up, the first knee jerk is to give people chemotherapy. Now, what is chemotherapy? Chemotherapy is the original cytotoxic therapy. In other words, it's like literally using a flamethrower in a confined room to kill the one fly, right? You'll probably kill the fly, but think about everything else you're going to destroy in the process. And compare that to the fly swatter. That'll kill just the fly. So what we have developed is we've developed fly swatters. So if you look at things like CDK4/6 inhibitors, so all hormonal therapies now should be given to women with breast cancer who have hormone-sensitive breast cancer. So that should be first-line therapy. Now, that means that that's how you treat these patients when they present first line, and that's how you treat these patients when they have metastatic disease. I've had, Carol will bear testimony to this, in the last month, 3 patients from very established units in this town that were suggested that they have chemotherapy for a disease process that was very, very clearly hormonally driven. Now, giving those patients chemotherapy is actually a little bit not helpful to them, because why? Very simply put, you're going to put them through so much unnecessary problems, whereas literally giving them a pill or 2 pills is just getting you to the same place, if not better. So that's one of the problems. The second problem is the innovation is sometimes not in the effect, but in the negating of the side effects. Okay, so sometimes the innovation is in causing no harm rather than in how much effect you have. So the age-old adage that in order for you to have effect, you must have side effect has kind of left with the arc. So you don't have to have side effect to have effect. We measure effect by, for instance, measuring how much disease you have. Is it getting smaller? What are the markers doing? Etc., etc., etc. So that would be a simple way of explaining how that kind of old day chemotherapy is no longer the best systemic therapy, which means a treatment that you take that goes around the whole body and gives you an effect.
Thank you very much for asking that, Dr. Moodley.
Absolutely.
Prof,
yeah,
go
let
ahead.
me comment on that. So my simple message is, don't rush into treatment when you've got a cancer. I'm not saying wait for months and months, but make sure you do due diligence. Anyone who tells you take your breast off, it's an aggressive cancer. I always say, if a cancer is aggressive, you need to start with oncology, not with surgery. Having some value of understanding how the cells behave before you start treatment is absolutely critical. Okay, it's not one size fits all, and what Devan says is 100% right. You've got to interrogate what is the right treatment, and it doesn't have to be just have chemo. It may be that you need chemos and immunotherapies. It may be that you need targets and CDKs, etc. But there's not one way, and it's about interrogating it so that you give the right options for the person. What is their physiological age? How have you assessed the disease, etc.? And we are really making rapid changes in how we manage cancer. And collecting today what I consider real world data, okay, is so important to understand what Devan mentioned is right. You want to know what is your proof that your treatment is working. Interesting. I had an interesting chat with Byron this morning about, he was like, oh, and this on the CDKs, and what happens when we had cytotoxics, and there's certain diseases that we knew in the past, and I mean, you've got all the oncotype and the genetic profiling doctors that we gave chemo to because that's what we gave, and the responses weren't great but they were okay. And then we look at what we do now, and the only way we get things better is show me the data. Innovation is about asking the question. It's about critical analysis of what you do, reviewing what you do, and working out with clever embedded ways. And the world is changing rapidly today in oncology from every aspect, diagnostics to understanding the cell, to oncology treatment, to smaller surgeries, to focused radiation, personalizing it so we get better patient outcomes, right?
Thank you, Prof. Before you go, I am going to direct a question to you based a little bit off what Dr. Moodley said and our previous webinar a week or two ago, which was on your comments on less invasive surgical approaches, which is a fantastic innovation to have.
Yeah.
I am going to ask the basic question, though. Does this not result in more radiation and other systemic treatments needing to replace those less invasive surgical approaches?
No, so great question. So the umbrella of care is oncology reigns supreme. When you've got an awake cancer, and I always say there are 4 different cancer families, TRPNEGs, HER2 enriched, luminal B, luminal A's. Each family has many different people in it. It's not just one size fits all. So if you have the data clearly shows today that breast conservation and radiation has a better survival than a mastectomy with radiation. So if you start by less is more, you can do more is more later. But it's a bit like if you had a melanoma and you would do a PET scan and work out if you need immunotherapies or treatments, and you cut out that little local area. You don't take off all your skin. A mastectomy is really a big lumpectomy. You can never take out all the breast tissue. And there's another very interesting field called ERIS. I spoke to one of our anesthetists who's just come back from the World Congress, and he commented on what you and me, Dom, often say is that, and Devan probably has the same thing, we go to these special meetings throughout the world and we go, oh, okay, are we going to learn anything new? Gee, we're doing it well, we're doing it brilliantly, but here's how we can fine tune it. And that concept, which is what Devan mentioned around immunotherapy. Our immune system is so important about why cancers develop and how we treat them. And if you do 2 bigger surgeries, you drop all that, and then actually you don't do the patient any favor. Okay, did I answer your question?
Thank you very much, Prof. That definitely does put some answer onto there. You did also mention a buzzword that I want to address. And Dr. Moodley, I'm going to ask you to take a look at this. There is a very scary word whenever you doctor Google breast cancer or any of those silly things that I don't recommend anyone to do, and that's triple negative breast cancer. When you were talking about systemic therapy earlier, Dr. Moodley, you mentioned the hormone-sensitive breast cancers. You mentioned the targeted therapies for CDK. Is there any innovations or something similar for triple negative breast cancer?
Well, first very important thing to be told about triple negative breast cancer is that it actually isn't one entity. So what people did is everything that didn't have a home got thrown into the triple negative breast cancer basket. So it's actually not one disease, it's many diseases. So in the triple negative basket, there are some triple negatives that are extremely slow growing and have an extremely good prognosis with literally surgery alone. There are other triple negative breast cancers that are aggressive. And then there are other triple negative breast cancers that have BRCA mutations, and they have a different trajectory of treatment. And then there are those triple negative breast cancers that respond well to immunotherapy. So before you take a disease process like triple negative breast cancer, you have to interrogate it carefully to find out, okay, triple negative breast cancer is one big basket. So in that one big basket, if you went shopping on a Saturday morning, is this poultry? Is this vegetables? Is this fruit? Which part of it is it? Then you take that out and then you look at that particular triple negative breast cancer. And then you can say, okay, for this one, for example, there were a whole lot of patients that were triple negative. Then we found out that actually their HER2 was 1 plus or 2 plus. Now, that is no longer triple negative. That is now HER2 low or HER2 ultra low. And there's specific treatment for that. That makes a very big difference to outcome, okay? Particularly in the metastatic space. Then there's triple negative breast cancer, which we call hot or immune reactive. So there are mechanisms to look at those patients and say, okay, these are candidates that need to have chemotherapy plus immunotherapy, because together they respond very well. Then there's the triple negatives who are BRCA mutated, or they have another mutation that is similar to BRCA that just doesn't have the name BRCA. Now, they would respond to a particular class of drugs called PARP inhibitors. If you have an access problem, say you're at the government sector where PARP inhibitors are not available, those patients respond to platinum agents. You see? So it's important that when you have a diagnosis of triple negative breast cancer, yes, it is scary. Yes, it is the new bad boy in breast cancer label, right? But even among that group, there are subsections. So it's very important to interrogate that very carefully.
Thank you so much, Dr. Moodley. And you bring forward such an interesting discussion there, because I look back at the label of cancer and cancer treatment, and we realize that that has been such an umbrella term that has been thrown at a wide number of diseases. And as these innovations and times goes by, we're delving in deeper and deeper into categorizing cancer into its different types. Even within breast cancer, there's our 4 general types that Professor Benn spoke about. And now you're educating us how in triple negative breast cancer, it's an umbrella term for multiple different sections underneath it. You also mentioned there our genetic markers. You mentioned BRCA amongst a whole other plethora of genetic markers that we see. And I think it feels like it's still fresh in my memory, but it's almost 15 years ago where the genetic testing and coming up with a BRCA positive hit resulted in people requesting to go for risk-reducing mastectomies as the answer to go forward. And it's sounding like now that there's systemic treatments available for that as well. And I am aware that you've spoken that it's not just the 1 or 2 BRCA genes that we're talking about. I've seen gene assays now that are 60 genes wide, 70 gene wide, even more. So the specificity that we're looking for at the different markers is incredible. And if you'd answer for me, I'm assuming systemic treatment is something that can be looked at for a large number of different treatments that you can get at, and that radical mastectomy or prophylactic mastectomy is optional, but is it still a recommended treatment?
It
So I
depends
think the
where,
thing,
and
yeah,
depends when,
yeah.
and it depends who, and it depends on personal choice. So
And I think
this is not one person, one size fits all. Carol, you can
yeah, it's
take that
not
one.
about, so there's understanding that you are BRCA positive and you don't have a cancer, and understanding you're BRCA positive and
Yeah.
you do have a cancer. So you've got to separate the two out. There's risk reduction because I'm fearful. I'm changing where I live because I'm worried that if I live, and I often say to people, it's actually more dangerous living in Joburg. I'm worried because of where I live that I need to do something to protect my home. Okay, and even if you do risk reducing mastectomy and you're BRCA positive, fine. Okay, it doesn't mean you still can't get a cancer, right? And then there's having a cancer and being BRCA positive. Treat that cancer. The BRCA can help the oncologist, and I'm going to ask Devan to go a little bit more into the BRCA test of you as opposed to the BRCA test of the cancer to help specifically work out how we treat that cancer. So once you've got a cancer, treat the cancer. That's not when you turn around and say, I'm moving house. Okay, so you must separate the two. You want best outcome from your cancer, and you want to separate it out because I'm fearful of, because I have a higher risk of something, I'm going to do something about it. I'll leave it with you, Dev.
Yeah. Remember, in the early stages, okay, you have, very simply put, you have patients without cancer now saying, listen, I've got something that puts me at higher risk of getting a cancer in BRCA. And then what do you say? Okay, then what are your aspirations? When can we expect you to have any of these malignancies if the risk of these malignancies are higher? And then we would say, okay, under those circumstances, for instance, finish your family, and then let's look at reducing your risk for ovarian cancer. Let's reduce your risk for breast cancer, etc., etc., etc. Now, that is completely different too. If you have cancer, they have found you've got cancer, the cancer has spread to involve other parts of your body. At that point, going and doing a mastectomy or a bilateral mastectomy is a complete waste of time. Okay? At that point, for you to cut off your breast is a waste of time because you have got metastatic disease, and how we treat your metastatic disease will determine where you are and how much you survive. So now when we look at these type of mutations, understand there are two kinds. One is germline, and the other one is somatic. So what does that mean? Simply put, the germline is the one that is present in every cell. The somatic is that mutation that's presented in that cancer cell. Both of them still provide you with a therapeutic opportunity. So what that means is, if you have the BRCA gene or you have a BRCA somatic mutation, and please understand, it's not just one. There are many, many of these. There's PAL-B, there's a whole lot of them, right? So it provides you an opportunity to give you a targeted treatment, a PARP inhibitor, right? That will treat that mutation in both the somatic and in the germline setting. So what these tests do is they guide systemic therapy. So how does it affect modern oncology? In high risk individuals, in other words, in individuals who don't have cancer, who have this germline mutation. So that means one of their parents had it, they inherited it. When they did testing, they found that they have this mutation. we can then address which are the high-risk cancers and when they need to be attended to. In patients with disease, it guides a better version of personalized therapy. So be it somatic or germline, we then have therapies. And if, which is the case for the majority of patients, you don't have access to a PARP inhibitor, then we find that DNA damaging agents like platinum agents are very, very effective in such patients. I hope that gives you like a decent overview of that process.
I think that does, and I think it the data, as I understand it now, David, is even if you've got an early stage and you're BRCA positive, again, even if it's not metastatic, the issue is about treating the disease, because there's some great studies to show that people with those type of cancers who have BRCA, even if you do a mastectomy, it doesn't change your survival, or even if you don't do anything and you wait for your second cancer, it doesn't change your survival. What I do want to say is that not all BRCA is one group. So, for example, if you're BRCA2 positive, it's not just about breast. So when people come in and say, I'm taking my breast off, I'm like, have we scanned your pancreas? Have we checked your entire gynae tract, your skin, your GI tract, etc.? So I'm always fascinated by, and I always say, you have this genetic since the day you were born. Sadly, we can blame our parents for everything. Okay, look at my mom, look at my dad. Okay, so we are what we are, and we get a combination of it. And just because you've got the gene, it does not mean that 100% of people with BRCA positivity get a cancer. It's about 65%. So I think that you need to separate the two, treat what you've got, understand your risks, and go forward in a careful, innovative way. And I think AI will play a huge role in genetics. I think we're particularly poor. Even when we do like 70 gene assays to look for genetics, we're looking for single isolated things that stick out like a light bulb. What it's about combinations, like we have combinations opening a lock. You have different lock combinations for each families. And this is where I think that computer logarithmic learning will play a big role in terms of recognizing combinations that we ourselves can't pick up.
Thank you very much for that, Prof. And thank you very much for that explanation, Dr. Moodley. In just a moment, I'm going to go and address some of the questions in the chat. However, before I do that, I do want you to answer one last point on the systemic treatment that you mentioned, and I felt might need a little bit more of an explanation. And that's where you mentioned immunotherapy. And off the top of my head, that sounds like getting someone's own immune system to fight the cancer. I'm not sure if that's a misunderstanding or a little bit of a urban myth to it, but please could you just elaborate a little bit more what we are talking about when we mention immunotherapy?
Well, it's exactly that. It is getting your body to treat the cancer. So, facetiously speaking, immunotherapy is the biggest con in modern medicine. You pay vast quantities of money to give a patient a drug to tell your body to do the work. So your body is doing the work itself, but it doesn't know it needs to do the work. So there are different kinds of immunotherapy. Okay, so the commonest kind you get these days of immunotherapy is actually a healthy body. Okay, so if you have a healthy body with a good immune system, in other words, as a child, you were exposed to many allergens and pathogens, and you developed yourself a very strong immune system. It recognizes things that shouldn't be there. It fights it off. So that's a very big determinant of how one does. And that's the first kind of immunotherapy. Raise your child right. Don't protect it too much and allow it to chew the end of the broom when it's a child, because all those allergens will make its immune system stronger. And I know, I had to personally witness this over the weekend. It took every bit of self-control not to rip that broom away from my grandson as he stuck it down his throat. So that's the first kind. The second kind of immunotherapy is the drugs we give people. No, let's not get there. It's a healthy diet and exercise. So those are the two mechanisms that one keeps one's immune system healthy and functioning. No supplements, exercise, and a healthy diet, a balanced, healthy diet. So those are the other two things that make your immune system strong. Right. Now, these days, we have different immune agents. So we had an immune agent a long time ago. We called it interferon. And interferon we used to give patients who had melanoma. We should give patients who had chronic myeloid leukemia. And it boosted your immune system, and it worked on the premise that a boosted immune system with more interleukins and cytokines, which is basically the thing that gives you a fever when you have a viral infection, will fight the infection. Okay? And it worked for a small percentage of patients with those disease processes. Today, we know that one of the ways cancer beats patients is its ability to evade the immune system. So cancer does that by blocking those cells that see it and present the cancer to the immune system to fight. So what we have now is we have a class of drugs called checkpoint inhibitors. And what they do is they bind where the cancer cell would have bound on the immune system. That way, they don't cloak the cancer cell, and the immune system can see the cancer cell. Okay, so these drugs are now checkpoint inhibitors, right? And so you call them PD-1 inhibitors or PD-L1 inhibitors. So they are the first phase of development in terms of augmenting the immune system to fight cancer. In development now, when we look at that cascade, there are a myriad of products that work on each side. There's LAG3, there's a whole lot of those drugs. And what they do is they look at either preventing inhibition or augmenting response in terms of getting your immune system to work better, A, at recognizing the cancer, and B, doing something about it once the cancer is recognized.
Thank you very much for that, Dr. Moodley.
So,
Definitely
Devan,
answered my question.
I love what you say, but I am going to say when you've got a cancer, your immune system has failed you. So I have a really blunt explanation.
It's left the building.
I have a blunt explanation to say, and I hate to use the analogy. It takes about 92 abnormal divisions on a cell to develop a cancer. I used to think of it like a snowball. It's more like having, hate to use war analogy, about 92 different drone strikes, and you have an abnormal cell. If your repair genes can't fix it and your hyena cells, which is your immune system, can't kill it, then you get a cancer. So at that stage, guys, trying to boost your immune system with healthy diet and exercise, important, but now you need some help. Now you need to call in the A-team. Okay. What would you be? Would I be Mad Dog Murdoch and you would be B.A. Baracus, or would you be the Colonel? I think you could be the Colonel. We need to get help now, guys. You need to get
you a name tag for that, Prof.
A-team help to help your failure of your immune system to reboot. Okay.
Thank you so much. I'm going to take this moment to take a look at some of the questions we've reached in the chat, which had a little bit of a more personal point to address on. Feel free, either of you, to answer these questions if appropriate. I am going to start this off with a caveat that a public webinar forum does not replace a doctor's consult, and the answers you will receive here are very vague and academic and not personalized for you. And I think we've all heard how much of the discussion tonight has focused around personalized oncology is the direction that the innovations are going. I'm going to start us off with a very vague one. And I believe, Dr. Moodley, this came after you discussing about how there are so many different types of triple-negative breast cancer. The question reads that, will the oncologist be able to share which type of triple-negative breast cancer I have been diagnosed with? I was diagnosed with TNBC with aggressive treatment and noted as grade 3. But how would I know which one?
Well, unfortunately, that requires a better interrogation of all the circumstances of your diagnosis. Okay, now that can only be elucidated by your oncologist. And unfortunately, that requires a bit of time, a little bit of insight, and a little bit of patience. And even if they go through all of that, they may find that actually they still give you a rather generic description because there is still a fair amount in the middle of that entire group that says, I just have triple negative breast cancer. So as much as you can split those things out, there's still some that sit under that umbrella of just a triple negative breast cancer. So your doctor should be able to answer that, but it's not a given that they will.
And if I can probably just
Yep.
add on to that, and this is more of a guess than an accurate answer, I'm sure that delving down into the different subcategories of triple negative breast cancer or any type of cancer, we're talking more diagnostic tests,
Yes.
more pathology tests.
Yes.
This is going to be an added weight onto your personal funding or medical insurance or anything. So
Sure.
the degree of how deep you're going to dive is obviously dependent on how many of these tests you're going to have done.
Yes, but that delving would needed to have been done at the get-go in order to make that decision on your therapy. We don't
Absolutely.
necessarily
Absolutely.
say which one it is, but that is integral to decision making before deciding how one treats you. For instance, okay, you may have BRCA. Now, BRCA is different in terms of the types of breast cancer to the basal-like 1, the basal-like 2, okay? You may have the luminal androgen type, okay, which means that this would actually be less responsive to chemotherapy, but more responsive to anti-androgen therapy. So all of those things come into how one is treated. For instance, these days, when we look at patients in our MDM, particularly the triple negatives, we ask about the immune cells. We ask about the TILs. Now, that is very important because that tells us, okay, what is the chances of chemotherapy working with immunotherapy? So all of those things we have to make, even if we just do it in here and don't communicate it to the patient, we have to make that assessment up front. Now, if you wanted to know that, your doctor should be able to tell you, listen, at best guess, this is where you fit.
Thank you very much for that answer. Moving on to our next personal question, and this one feels very personal, and there are almost two questions involved here. The first aspect is asking very simply, are there any new innovations in radiation for breast cancer? Then the question goes on to give very specific details of their situation. ER positive, HER2 positive, they had a lumpectomy done, they're undergoing Taxol and Herceptin, still have some to do, and they have been told that they will still have to do radiation. And they ask, are there not risks involved with this, such as lung fibrosis, because their radiation will no longer be targeted because the tumor has been removed? Perhaps we can address both sides of that question.
Okay, so I have no problem with the patient having a lumpectomy and hopefully a small gland dissection. I'm interested in the patient having then Taxol and Herceptin post-treatment. From an oncology point of view, my little eyeballs just went up because usually, sometimes in these patients, you'd start with oncology treatment. We always discuss it first, and it doesn't necessarily have to be chemo, number one. Number two is if you have a breast conserving surgery in this scenario, yes, you do need a small amount of radiation. It is completely de-escalate. Radiation is like thinking of a wedding cake. You have 3 different layers. If you have small tumors, nothing in the glands. You have a smaller sized cake, and how they cut the cake and what machine they use into how many slices determines how you give it. So it's absolutely, yes, de-escalated, and it depends on machines and doctors, etc. But the radiation fibrosis data is based on old data and how they use fancy computer-generated techniques and different aspects around the machine, and which side, whether it's left or right, decrease that significantly today. Devan, I don't know if you want to comment on that.
I just want to add just a few comments on that. Firstly, the innovations in radiation come from the innovations in software. Okay, so that's the advances. It's the software innovation. The actual tube with the linear accelerator is the exact same thing we've been using for the past 50 years. We just worked out how to deliver it better. Okay. Number two, the management of radiation these days involves doing it by cutting up into little bits and giving it over a shorter period of time with the same effect, or concentrating it all into a smaller period of time. So we can literally give the same amount of radiation we used to give over 6 weeks in 1 week without too much going on, except when you do that, you get more local effects. So you compromise your aesthetic outcome when you do that too much. So that's important to understand. The third thing about radiation is almost without fail, you will need to have radiation if you've had any kind of breast conservation surgery, because the rest of the breast, we don't know what's going on there. So we radiate the breast to sterilize that area. We do make exceptions with older patients, and we make exceptions for patients with very low proliferative index disease. In other words, with exceptionally slow growing tumors. But again, these are broad concepts that may or may not apply to you. So let's make this personal. Almost without exception, every single patient with HER2 positive disease will end up having radiation. Understand that.
Yeah.
Okay, so for you, yes, radiation is probably necessary. And I can say that without knowing the details of what else has happened.
The question is the Taxol, if they're giving.
So, yeah, that's a separate matter.
Okay.
I sidestepped.
You sidestepped that. So
yeah,
what
I
I'm
can't
saying.
comment.
Yeah,
I did not see the patient. I don't know the details.
Yeah. So what
Thank you
I
very
am
much
saying
for
is
answering that.
personal. It's personal. Each person, it's personal about what you want to do. Local radiation induces some form of immune reaction. And Devan's spoken a lot about your immune cells, etc. So it's personalized for each person. T's and C's applies though. So a webinar is not the answer for sorting out personal questions. What you need to do is seek out appointments. You need to take time, work out all your options, make sure it's
so much,
reviewed
Prof.
and a reputable MDM. Thanks. Bye.
One other thing, Dom.
Yes.
Just the thing about radiation, pneumonitis. It happens to the majority of women. It will not affect anything in your functioning. It's a little bit of lung, a sliver of lung that's sometimes exposed. The only people that are affected by this are Olympic grade athletes who then cannot break world records. So the majority of women, this is just something that presents as a small abnormality on a CAT scan that you will see for many years going on. It will not affect you in the slightest. So it's just important for you to understand that.
I feel we have answered everyone's questions on radiation there. It did cover all the topics that came through. Yeah. I have two more very quick questions that I'm going to ask from the chat before we move on to another discussion that I think is relevant. Paraphrasing this question, someone who is in cancer survivor, is there any other way to check if the excuse my pronunciation here, fibroadenomas that are picked up on their annual mammogram are cancerous besides a biopsy?
Carol, this one's just for you.
Fibroadenomas are seen better on ultrasound than mammogram. If you're not going to have a biopsy, not everyone needs a biopsy. You need short-term follow-up ultrasounds. If they grow, then you do a needle biopsy. Common in young girls. Okay, it is what it is. The buck is the buck. The jackal's the jackal. The lion's the lion. The question is, have you with your binocs picked up the right thing? So the only way to do it is to drive around the bush, have a look again. If it looks like it's bleated or moved or doesn't look like something it should be, then you'd use your high resolution, Bernardo would love this, camera, and you take a picture of it so that you know what it is. I can't do shoot,
Thank
so
you,
that's not
Prof.
my thing.
Clarifying the questions. They've
Core
been having
biopsy.
mammograms since they were 38 to 46. Now, every year they've been asked to do a biopsy
Okay, has
alongside
it remained stable? If it hasn't changed, it's probably just a buck. Okay.
Okay.
It's not going to sit
Then,
there as a cancer for a
then the last active question here is a cancer survivor for 11 years. Is it worth doing the test for BRCA or other genetic mutations now?
So there are
for your family if you want. Okay.
there are specific indications for genetic assessments. Okay, so if you have a positive family history, if you've got other cancers, if your cancer presented under 40 years of age, if you've had a triple negative breast cancer, all of these represents what we consider higher risk groups for genetic aberrations. So those were the risk groups we would recommend it in. For the rest of the general population, if you wanted to do a genetic test because you were interested or you wanted that peace of mind, the recommendation is that you do this via a genetic counselor, because it's not just go and do a test, it's first have a chat, understand the consequences of what that test is, when one would do it, and what are the consequences of getting a positive or a negative answer. And all those things need to be discussed before one does the test. So it's actually the poster child for informed consent.
Thank you so much, Dr. Moodley. And before I start my next question, a quick fire, one or two questions. Is CDK treatment available in South Africa?
For a long time now.
What is your opinion on portable screening devices for early detection?
Carol, you want to take that?
Yeah.
I'm not a fan.
Yeah. So
in the land of the blind, the cockeye is king.
Absolutely. So the thing is, you've got to work out where you've gotten what from a cost-effective point of view. So I'm not a fan of things like AI ultrasound as a pre-screening to get people into doing core biopsies and proper radiology. So I think you've got to look at what are your McDonald's drive-through to separate things out, and then in terms of your details, devil around the details when it comes to oncology treatment. So I think the first step is examine your breast, know your body. If things don't look or feel right, okay, make sure that you are going to reputable units. No problem with starting with AI ultrasounds and quick checks, but they have to be followed through with further.
Thanks, Prof. And now I want to move on to my second major discussion tonight, which is going to be on new... Yes?
Before you go there, ladies, please realize when you get treatment for your breast cancer, you have surgery, you have radiation, you have reconstruction, you will have abnormal sensations in that breast and sometimes some pain in that breast. And sometimes this goes on for years and years and years. Okay. So just merely having pain in that breast should not worry you, but you should check it out.
Thank you very much, Dr. Moodley. Going on to my section 2, and we'll take about 10 minutes to discuss this, is new developments, and I want to focus on the word clinical trials. As a patient, I'm going to ask some of the basic questions, and I feel free to shoot me down, but when I hear a doctor mention clinical trials to me, does this mean the medicine that I am going to receive or whatever procedure I'm going through is not as safe and is not tested yet?
The simple answer to that is yes and no. So the typical clinical trial design is that, number one, the investigational product that is being tested is not never been tested in breast cancer. It's just never been tested in this indication. And please bear in mind, when they put up a new therapy in an indication, they are almost sure that they'll get a positive result. And that's why they want to do the trial, because they want to market and sell it for that indication. So before it's got to that level of testing, it has been pretty intensively interrogated. So yes, there is a small chance that when you go into a clinical trial, if you are randomized to the investigational arm, that it may not be as good as the standard of care. But be aware that for a clinical trial, the control arm, in other words, at very worst, your control arm is always the standard of care. So why do we put people on clinical trials? A, to get them brand new medication that we actually want them to have, because we firmly believe it's better for them. Or B, because we know at very worst they're going to get standard of care, which sometimes they may not be able to access if they're on a inferior insurance plan, or if they're in a state sector where those therapies are not available to them.
I'm not going to ask you to define an inferior medical plan, because I'm going to say that, right.
You know, many of these medical plans are considered basic medical plans, where they're going to give you PMB level of care. That means they'll give you just what is available at the state sector. So now my personal opinion is, I don't understand why you need to pay money to get the same level of care as they offer you at child care. Theoretically, that's for the so-called indigent South African patient, the South African patient who cannot afford a medical aid. So my personal opinion is medical aid should provide better than PMB level of care. But unfortunately, that process has been abused.
We won't delve too much into that discussion, Dr. Moodley or Prof Ben. One or two more questions around clinical trials. So if a clinical trial is suggested to me as a patient, what steps do I need to take doing this? Is there a difference in clinical trials that are offered in public versus private? What do I need to know after it's been mentioned to me that I might qualify or be up for a clinical trial?
So a clinical trial is usually investigating either a new treatment, a new indication, or a new treatment pathway that the doctor will then be saying to you, listen, here's a mechanism by which we can get you this type of care. So the first thing about a clinical trial is you'll get referred to a clinical trial center. In a clinical trial center, you'll speak to a clinical trial coordinator that will go through the inclusion criteria with you. They will tell you what the trial is about. They will tell you what the trial entails. And then they will tell you what are the things that you need to fulfill to be on the trial, and what are the things that will make you no longer qualifying for that trial. You will then get that document to read and or take home to decide, are you going to be participant or not? Once you've decided that you'll be participant, you will sign a consent. That will be the whole informed consent process. And usually that's not at the same sitting. So usually you get some information, you take the information home, or you discuss it with your husband, your family, whoever, and then you come back to the clinical trial coordinator and tell them, yes, I am in, or no, I prefer not to have anything to do with this trial. The difference between trials done in the public sector or the private sector is sometimes you can't recruit for some trials in the public sector because it would, for example, need you to be on a particular medication that nobody in the public sector gets. So they wouldn't recruit for those trials in the public sector. So they will only be able to recruit for those trials in a private sector environment because it's only in that environment that they might have got this trial, this drug. Okay, so that's the
Thank you so
difference.
much for that. Thank you so much for that. That's very informative. I'm going to throw one last firework into the discussion here, Dr. Moodley, and ask regarding medical aid coverage for newer treatments, for these innovations that we discuss. What options exist for these treatments? Does medical aid cover it? Or if they don't cover it, how would one go about accessing them?
Okay, so there's one thing you need to understand about the newer treatments. I think without fail, most of the funders, and when I say funders or insurers or medical aids, I'm talking about these large entities where you pay a premium every month and they provide a level of care. For the newer therapies, it takes them a fair amount of time before they discuss whether they decide are they going to pay for it or not. Number one. So there's a whole group of medical aids that say, no, we don't pay for it. Secondly, there is a bunch of medical aids that will pay for something that's new, but they will put on a co-payment, right? So anything between 20, 25% and 50%. Then some of the companies that manufacture these drugs, they may decide to assist you with that co-payment. And there's a process to apply for that through one of these different foundations, these not-for-profit foundations. Then you apply for that, and then they'll pay a particular percentage. But in some cases, and this is true for quite a fair percentage of cases, there will be a co-payment that you will need to be footing if you want that treatment. And that can be anything from 5, 10 up to 25%. If the medical aid doesn't pay for it at all, you might still be able to apply for that co-payment assistance, but then the amount you will fund will be up to 50% of the cost of the drug.
Thank you very much for clarifying that. And before we move on to one or two more questions, and there won't be a lot of them, is there anything that is emerging in the realm of clinical trials that excites you or you, Prof. Ben?
Carol, anything you find that you're looking good?
Absolutely. So I think the ability of us to do smart biopsies, the ability of us to work out when we're not doing lymph node surgeries, when we're not going to be able to operate. So I think it's a very exciting future in oncology, but it all means careful attention to detail, multidisciplinary review, not rushing in, having all your options laid on the table. And I think we are in for a very exciting future. So that's
specifically from a trial point of view right now, Prof. Are there any medical trials that is a exciting buzzword for you?
Well, we've just got the Lancet review on RT with the immune thing. So that's in the
IRT as in radiation therapy.
Yeah, intraoperative radiation therapy is now just hit the Lancet. Oncology, obviously I can't go over any of the releases. I think cryo, the FROST trial with the immune benefit on it, avoidance of surgery. I definitely
Can I put a
think,
pin in it right there, Prof? Because your mention of the cryo-frost trial actually does address a question that has just come up in the chat. Is cryoablation only used for small tumors? Can it be used on other cancers, and does it replace surgery?
So it can replace surgery, but only in small luminal APAN cases. So at the moment, not for. And where I see emerging in the future is maybe for PCRs, complete radiological response in patients with other type of cancers. But currently it's for small luminal A cancers, excuse me, I got hiccups, in people over the age of 65. So, life is changing. It's going to change fast. And I think everyone should watch the space and work out what their options are before rushing in.
Thanks, Prof. So anything on your radar?
Yeah, there's an interesting trial that will open in the next couple of months. So to set a scene, prostate cancer has radioligand therapy. That means they do a PSMA scan. And what that does is that lights up in the body every place we think there's prostate cancer. Then we do an actinium scan and we give them a radioligand that binds there and radiates only those areas in your body where the cancer showed up. Now, there's going to be a new trial starting the next 2 or 3 months where they have a similar scan for breast cancer, okay, where they can light up where all the metastases are, tie in a radioligand, and that can be a diagnostic, and thereafter, the same process, a therapeutic scan. Now, that may offer significant palliation, and it may lengthen the survival of many women with metastatic breast cancer significantly. So that's coming soon. It's interesting.
I've been watching
That
this
sounds
work
fascinating.
since
Yeah, it's very interesting.
2013. I've been watching this work where they label things to PET scans and everything. And I think we are in for an awesome and really, really exciting future. Also
And I
looking
think
at,
that when that trial opens, I'm going to send almost every metastatic patient that PDs for the scan. Because
100%.
then, if they can get the scan and it shows us it lights up, and the next week they can get therapy, it will change. It's just adding in one line of therapy with God knows how long PFS. When I say a
100%.
PFS, I mean a treatment-free period. If I can get women with metastatic breast cancer a month, not a month, a year, 2 years without therapy, oh, it changes the game, guys.
Absolutely. I mean, I think, Devin, if you look at the fact that I sent it to Byron just to play on his mental anguish of the concept of, I mean, the studies now where you give a single dose radiation or you turn cold tumors, hot tumors, and then add immunotherapies into them. And I sent it to him because I was like, you want to operate on this after they've had a single. So I think we have an exciting future, and that is really where we're using radiation to change the behavior of the tumor so that the oncology drugs can work better. I don't know if you want to expand on that.
Yeah, and I think what's going to happen is we're going to use radiotherapy more and more and more to do a few lesions, if the few lesions is all we can see. So I already often do with patients, we target a particular area that they've progressed, and we continue the treatment they've been on. And then what we can do is we can keep them on treatment for another 6 to 9 months without any progression. Now that makes a huge difference to a patient with metastatic disease, because what you do is you keep them well for another year. So that's a big plus.
That sounds amazing. There is one final question that I want to answer tonight, and I'm going to be cheeky, Dr. Moodley, and I'm going to try and include a personal question from the chat just before I ask my question. This is very dependent on a patient's specific treatment plan and environment, so feel free to sidestep this if it's not appropriate for you to answer. But they were unsure about the price of immunotherapy, and they want to know whether it was worth it or not. They have completed their chemotherapy along with 3 immunotherapy doses and have just had their lumpectomy. Is it worth doing the remaining 3 doses of immunotherapy? And if so, when is the best to do it? Before or during their radiation or after? And then the final point on this question is there a specific test I can ask before proceeding to the immunotherapy? And I'll give you a moment to see if you want to answer any of those questions.
Let's go backwards. Is this a triple negative breast cancer?
A triple negative breast cancer, they asked the doctors before starting the immunotherapy at PD-L1 and TILs, and they said it did not matter.
Okay.
Either ways, the immunotherapy will respond well.
Okay.
And then they had their chemotherapy. Yes.
At surgery, what was the result? Was there residual disease?
We do not have that information.
Okay, so if there was residual disease, then the immunotherapy after surgery is of benefit. And I don't know where the numbers come from, but the total duration should be a year, not 3 treatments. Okay.
Okay.
So that's the first thing. The second thing is, If at surgery there was no residual disease, nothing, then the benefit from the immunotherapy is questionable. And in those patients, if they were not in a position to fund it, I would say, don't worry about it.
Thank you very much. And this leads me to my final question on innovation to our two specialists tonight. In this era of rapid innovation, what key questions should patients consistently ask their treating doctors about their treatment?
I'm happy to go. What I'm happy to go is your key question is, don't rush in, understand the information, make sure it's reviewed in an MDM, don't rush in, okay? Make sure it's personalized and de-escalated, and you are speaking to people who are super specialized in the field to give you different options. No question about that. I hope I answered that.
Yeah,
Thank you,
you
Prof.
did. You did. You see, we often have a situation where people come and they come with an opinion from theoretically a multidisciplinary team, and it's an opinion we don't agree with. So then you sit with a quandary. And you can imagine if you sitting with a quandary, what the patient feels like. The patient doesn't know who to believe. And then they in effect tailspin, right? So the first thing is, yeah, get more than one opinion, okay? Because usually, if the two opinions tie, you're sorted, you're good, you carry on. So I'll give you an example. I've had a patient come to see me with what looks like metastatic luminal breast cancer. She was recommended to have chemotherapy from consulting another unit in this town. I said, no, standard of care should be hormonal treatment, right? Which includes a CDK4/6 inhibitor. She then got an opinion from a specialist in Israel, who then wanted her to have a biopsy of her mediastinal lymph node and her rib metastases, which were all hot on PET scan, because it would have made a difference then whether she was metastatic or early stage. And I said, listen, ma'am, firstly, none of the bone lesions have the periosteum breached. So we can't biopsy any of these lesions without taking you to theater and cutting out a bit of your rib. And that is madness. So I don't know how this man can give you that as an option if he looked at the PET scan. And secondly, a mediastinal lymph node would require a thoracoscopy and or a thoracotomy to get to that node. And for what is almost definitely metastatic disease, this sounded to me as ludicrous. I reckon, let's do it this way. Let's give you 3 months of systemic therapy. Let's give you 3 months of endocrine therapy and aromatase inhibitor, letrozole, plus a CDK4/6 inhibitor, plus something for your bone. And let's rescan you in 3 months. You would have lost nothing. We can see, and I would not have put you through a bone biopsy and a thoracotomy to find out what? Nonsense. Because I know this is metastatic disease. So here's your problem. Your opinion is only as good as where you get it from. And sometimes you're not in a position to know if that's been a good opinion or not. So I can only sympathize with patients who are often stuck in the middle, who get strange opinions and then have to make a decision.
Yeah. So, Devan, I always have a rule. When I see people, I say, your body, you can have as many opinions you like. When you come here in these rooms, don't tell me what anyone else has said, because I'm going to take a history, examine you, get you to record what I say. And I mean, then you can walk out of there and go, that nut. What I do like about the unit is that the fact that everything's internationally accredited, it means show me the data, and we've got big brothers looking at you. So it means we are not just going small pond, big frog, where everyone goes, I'm doing this because I'm here and I'm the best and I'm the this in South Africa. What I want to be is I want to be zoned and interrogated all the time by what the considered top in the world are doing and making sure that I can have good outcomes for my patients. So, and I
I love
thoroughly
what you
love,
said there,
I
and I think you're
love
going to
working with
give
you,
me
Devan.
the opportunity to give my own best innovation in breast cancer. And that is because due to tech and due to the way the world has shrunk and we can share all our information, that the best innovation in breast cancer we have is the digital tools that we have to assist us all, is the fact that all our discussions can happen for every single patient on the digital forum where we can look at every single bit of information that is put forward towards that patient. That is about all we have time for
Before you
tonight.
stop, I
Go
want to be
ahead.
provocative for one
Please
last thing.
do.
Sometimes, do not be confused, we are ahead of the curve. That's all I am saying. We
Yes,
are
that is true.
sometimes ahead of the curve compared to what the rest of the world is doing. And
100%. I
so
test to the
it's
teams last
hard.
night. Yeah.
Yeah, it's hard for me sometimes to be able to tell patients, listen here, you don't need chemotherapy for this. I can get you to the exact same place by taking 2 pills on a daily basis.
That
That's
is a
all.
good point.
Yeah,
Keeping in perspective where we sit and what we do and holding everyone to their
yeah.
own standards as well is relevant. Thank you very much, Prof. Ben and Dr. Moodley, and all the attendees for your valuable insights tonight. We hope you feel more informed and empowered to engage actively in your care journey. Stay hopeful and stay informed. And the largest thank you to the Breast Health Foundation, who without their continual work in hosting these webinars, in creating a platform to us to have these discussions, we would not be able to have these active debates and provide these insights to our audience who joins us tonight. As always, I'd like to give an opportunity for a representative from the Breast Health Foundation to close out our discussion tonight with some comments from them.
Thank you so much, Dom. I think we've covered so much in this webinar. So just a biggest thank you to Prof. Ben and to Dr. Moodley for joining us tonight and sharing all of this fascinating information. Thank you to everyone that joined us tonight. We're so happy and lucky to be able to share all of this information with our community. So thank you all to everyone, and to Dom for facilitating, and have a good night.
Thank you so much. Please keep your eyes on your social media, however you heard about this webinar, because there will be more of them as the year goes on. We will also be providing a recording of this webinar on the Breast Health Foundation's social media. So if there was anything that was discussed tonight you want to look at or that you think someone else would benefit from, you can share that with them. And we look forward to seeing you at our next webinar. Good night, everybody.
Good night. Good night. Cheers, Dave.
Cheers. Cheers.